Kapoor, sir.
Sure, sir. Just give me a minute. Technical support team,
Yes, ma'am.
just give a countdown.
We are going to live. 3, 2, 1. Go live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Oncology Express. And with immense pleasure, I would like to invite Dr. Major General B.N. Kapoor, who is Director, Medical Oncology, Yashoda Cancer Institute, Ghaziabad, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Yeah, thank you very much. It's an honor and a privilege to be a part of such an allied conference to discuss latest things in lung cancer. Oncology Express, as the name suggests, it's an express thing which will be discussing all the newer things which are happening in lung cancer. When we were young medical oncologists, lung cancer used to be a very dismal disease with few months of life. But with the advent of new molecular markers like EGFR, ALK, BRAF, MET, PD-L1, lot of newer things are happening and targeting the newer molecular targeted therapies are coming for the treatment of lung cancer. To discuss all these things, we have a panel of experts in the field of management of lung cancer, and it's an honor to listen to them. We will be discussing whatever the latest happening in the management of lung cancer. And to start with, I will invite Dr. Rajat Govind from Delhi, and he will be speaking on it's time to target MET. Like I told you, a lot of molecular markers have come for the management of lung cancer, and to identify and to target this MET target, Dr. Rajat Govind will be speaking on MET targetable therapies. Dr. Rajat, please.
Good evening, General Kapoor, sir. Very nice to see you and hear your voice, sir.
So nice of you, Rajat. Thank you very much.
Good old times, sir, back in the day when we were all students under you, sir. As Dubey sir told, you are the big branch and we are all the small leaves.
I think the newer generation is doing much better, and I'm learning from each of you.
It's really an honor, sir, to look at you and to hear from you. Really nice, sir. May I request the technical team to allow the screen sharing, please? Yeah. Can you see my screen?
Yes, sir.
Okay. So maybe proceed, sir. Kapoor, sir.
Yeah. Please.
All right. Very good evening, everyone. First of all, I must thank Merck for providing the slides. And it was really informative. As we go through the slides, we'll come to know. So as rightly pointed out by General Kapoor, sir, lung cancer is an ever-expanding field of new innovations, new molecular markers. As the days progress, our understanding of this molecular pathology is increasing. And now we are in an era where we are targeting and really into the precision oncology. We are targeting specific molecular markers, which we are able to diagnose real time, and we have innovative molecules against it. So one of them, the new chip on the block, is what we are going to discuss today. Coming to the disease burden and biomarker testing, we all know this is the data from Globocan 2020. We are still most of the Indian males here, 8% of cases in males and 3% in females account for lung cancer in India. It is, of course, the second most common cancer in males and the 7th in females, and out of which we all know that non-small cell, which accounts for about majority, the 80 to 85% of lung cancer cases, with adenocarcinoma being the most common histology. So the new kid in the block, apart from the routine, we all know that EGFR has been the poster boy as far as the precision oncology is concerned, not just in lung cancer, but in all solid tumors really. It has really changed the paradigm of future for these patients who otherwise have a very dismal outcome. So the new chip on the block is MET exon 14 skipping alterations, and this drives the oncogenesis in non-small cell lung cancer as about 3 to 5% of cases, as we'll see. And this disrupts this MET gene, which actually disrupts the MET gene, exon 14 skipping mutation. It disrupts the usual MET signaling pathway, and which is responsible for the ubiquitination of this MET protein as a result of this skipping mutation, which increases the number as a result of MET receptors on the cell surface as they are not degraded. And this increases the MET driven signaling oncogenesis. So as I told, this MET exon 14 skipping alterations can be found in about 3 to 4% of patients with non-small cell lung cancer. And if you see the usual diagram of the responsible driver mutations, it is of utmost importance to understand that molecular testing is of paramount importance in identifying those patients of non-small cell lung cancer who may benefit from targeted therapy. So coming to the guidelines, what do the guidelines say? The guidelines, of course, re-establish our firm belief that it is important, first of all, to establish the histological subtype, and then we can, and with adequate tissue to consider molecular testing. And smoking cessation and counseling goes hand in hand, integrated palliative care, of course. So once we diagnose the patient with this specific histological subtype, whether it be adeno or squamous cell cancer, we go ahead with the molecular markers. The usual ones are the EGFR mutations. Of course, these are category 1 recommendations, along with its partners, ALK, RAS, ROS1, BRAF, and TRK, and now, of course, the MET exon 14 skipping mutations. Testing, of course, should be conducted as part of a broad molecular profiling rather than individual genes or just hotspots. PD-L1, of course, is one of the other category 1 recommendations to be tested in a patient with stage 4 non-small cell lung cancer. It is also important to note that squamous cell cancers also might, even though a minority of them, but they do also harbor at times EGFR mutations and BRAF and TRK HER2 mutations. So it is recommended to consider at least testing, which is part of the profile in squamous cell cancer patients as well. So what are the biopsy methods for detecting this elusive skipping mutation? So expert guidelines do recommend the biomarker testing, which can be identified via paraffin tissue or liquid biopsy. While we consider liquid biopsy, we all know that it's a simple blood test. It's blood sampling followed by extraction of the cell-free DNA and the circulating tumor cells. And this liquid biopsies, after a lot of processing, can be tested via RT-PCR or by next-generation sequencing. Solid tumors through tissue biopsy via the paraffin-embedded tissues, DNA, RNA is first isolated, it's purified, and thereafter a multitude of tests can be applied on them, which include RT-PCR, NGS, immunohistochemistry, or FISH. And currently, all the major bodies, NCCN, ESMO, etc., do recommend broad molecular profiling for oncogenic drivers, including the MET exon 14 skipping mutations. So these are few evidence-based consistent statements on MET alterations in non-small cell. We do have diagnostic and therapeutic considerations, and the Asian Thoracic Oncology Research Group consensus is that testing for MET exon 14 is recommended, and RNA-based methods have been found to be more accurate than DNA-based ones. Important to note that. While we order for a test, before we consume it as positive or negative, it's important to realize whether the test has been done using an RNA-based method. We do have other flexible biopsy options. While tissue biopsy, of course, will remain the gold standard for testing this mutation, liquid biopsies have now provided an additional value and flexibility, at least for those patients who are not suitable for tissue biopsy. If you look at it, wherever the tissue biopsy is not possible, and we often encounter it in clinical practice, patients may be frail enough not to go through a biopsy procedure, because of either comorbidities or general unwellness, or in certain situations, the tissue may not be enough. And in those conditions, liquid biopsy is a viable alternative. It may offer a better or representative view of genetic variations and the tumor heterogeneity, as well as real-time assessment of tumor burden, which may signal disease progression and thereby aid us in early detection. This is just a comparison with the conventional advantages and disadvantages. The disadvantages, of course, of a liquid biopsy is that it may not be actually suitable for all patients, considering the low yield in certain low burden diseases. So how has the treatment landscape changed? For patients with MET exon 14 skipping mutations, MET inhibitors have significantly improved the survival when we compare with conventional chemotherapy, which was the gold standard for these patients until we had MET inhibitors. So if you look at the overall survival in otherwise patients with MET exon 14 with chemotherapy, this was a small study which had two arms of 34 and 30 patients, roughly around 30 and 34 patients respectively. If you look at the chemotherapy arm, the median OS was about 8 months, whereas the addition of MET inhibitor or the use of MET inhibitor in this subset resulted in a median OS of about 24 months with a significant almost 16-month benefit. So with a hazard ratio, of course, of 0.1 with a confidence interval falling within clinical benefit range. It is also noted in these subset of patients that despite high PD-L1 expression, immunotherapy showed very minimal benefit in exon 14 skipping mutations. The MET exon 14 was associated with PD-L1 expression. However, low tumor burden, mutational burden was noted, and it was also noted that they had poor clinical outcome with immunotherapy. If you look at this diagram on your left, if you see the overall response rates of immunotherapy in about a very small subset of patients, about 24 patients, if you see, it was only just 17% overall response rate. It was quite less compared to what we expect out of immunotherapy in non-small cell. So it did provide limited benefit in OS and PFS. This is another real-world analysis of MET exon 14 patients from the Flattron Health Foundation. And if you look at the median PFS, it's about 2.7 months, whereas MET inhibitors, the median PFS rose up to around 12.3 months. So now, what do the guidelines say? The guidelines now recommend that MET inhibitors be considered as a standard of care in these patients. And the NCCN have now come up with guidelines which clearly state that in metastatic patients, the preferred first-line or subsequent therapy, as and when the diagnosis of exon 14 is done, is MET inhibitors. And in certain circumstances, we also can use the conventional ALK inhibitors like crizotinib as well. ESMO guidelines also have recommended this two drugs, tepotinib and capmatinib, which have demonstrated clinically meaningful efficacy amongst patients with MET exon 14 skipping. Crizotinib also has potential clinical efficacy, but that needs to be confirmed. Nevertheless, its off-label use is generally done in resource-limited conditions. So these are the current therapeutic landscapes. So what are the armamentarium of an oncologist have when he is faced with the report of exon 14 skipping mutation? We have tepotinib, and we have capmatinib, and we have the upcoming savolitinib. And if you look at the potency and the pharmacokinetics of it, more or less we see that tepotinib takes the cake here in terms of dosing as well, because it's 2 tablets per day. It's a once-a-day dosing. And we do have a one-step dose reduction, which I'll come to. Testing, of course, is recommended both by tissue and by liquid. Overall response rates of about 56% in overall group, where we have the Asian subgroup showing about 66% response rates in first line. In subsequent line, as expected, the response rates do go down a bit to 50% in second line and 30% in third line. But of course, that is expected out of any stage 4 disease. So this was the VISION study which established the role of tepotinib in this subset of patients. It was a single-arm phase 2 study, about 152 patients, and in the first cohort, and the second cohort was around 161 patients. These patients were all detected met exon 14 skipping through liquid or by tumor biopsy with no prior treatment. All of them were first-line therapies, or if they are exposed first-line therapies with MET, that is, and or they have been exposed to less than 2 lines of prior therapy. The primary endpoint was overall response rates, and tepotinib was dosed at 450 milligram daily. And out of that, treatment naive were 164 patients, and previously treated cohort was 149 patients. If you look at the overall response rates, it was about 36% for the liquid biopsy detected arm, but tumor with the tissue only detected arm, it was around 42%. So this was the first clinical trial of a MET inhibitor to prospectively enroll patients with MET alterations, which was based on liquid or tissue biopsy. And the tepotinib efficacy was established in these treatment-naive patients of about 111 patients. If you look about 60%, as the phase 2 studies had showed, the previous phase 2 studies had showed, around 60% response rates in this subset of patients, with a median duration of response of about 46 months and about median PFS of 15 and median OS of 25 months, respectively. It was also robust and durable in previously treated second-line patients as well, which was enrolled by tissue biopsy alone. In this case, it was about 50%, which was quite impressive in second-line setting, with a median OS of about 20 months in second line, which is impressive. So, if you look at the overall efficacy in patients in first line who are detected by either by tissue or by liquid biopsy, 60% roughly we can say in patients who have tissue detected MET exon 14 skipping mutation. So the liquid biopsy also was studied in this study, which identified patient characteristics associated with the worst prognosis, and in which it was found that the median tumor load of target lesions, if you see the T stage of it, is about 52 millimeters, and around 10% of them had brain metastasis. Amongst the patients who were liquid biopsy detected, if you look at the 159 patients, it was a more, as expected, a larger tumor size or a larger tumor burden, with about 68 millimeter the median tumor load of target lesions and about 15% of them having brain metastasis on diagnosis. So tepotinib also showed promise in a much needed subset of patients of brain metastasis. So it was important for establishing its intracranial activity, which is always a concern while prescribing these drugs, the new drugs. And it was seen that the intracranial response rates, or the DCR as we call it, was about 88.4%. And the intracranial median PFS was also 20 months, which is very impressive. Among 15 patients, those who had with target lesions, the intracranial response rate was about 66%. And so this was the efficacy of tepotinib as far as brain metastasis patients are concerned. So this is just an image to show a patient with brain metastasis who had achieved almost near 100%, in fact, by the 36th week of tepotinib. So efficacy of tepotinib was robust. It was also seen that it was not just impressive in terms of the overall response rate, but the median duration of response also was not estimatable in the study. The median PFS was about 15 months and the OS was not reached. In second line setting, as expected, the overall response rate was little less, but still, if you look at the median OS, it's 20 months in second line setting, which is quite impressive in this day and age. And it was also had a manageable safety profile, which is another concern which one needs to consider. If you look at it, around 30%, 1/3 of them did lead to dose reduction and the dose interruptions in around half of patients. Around 13% patients actually needed to stop the drug all throughout, and they could have had one or more dose modifications. There was no deaths in the study. So if we look at the specific side effects, I believe peripheral edema is the one concern with this drug. So peripheral edema was seen about 61% patients, and other side effects of concern were a bit of azotemia, diarrhea at about 1/3 of patients, hypoalbuminemia, and transaminitis. But if you see, most of them were below grade 3. More than grade 3 were very few of them. So this was about the safety. It was generally well tolerated across all therapy lines, with mostly mild to moderate events, with very few discontinuations, with about 10% of patients. So edema was another class effect, probably because of the potential mechanism of edema is as shown. Multiple mechanisms are in play, but it is generally believed that it is secondary to the inhibition of the vascular and lymphatic endothelial tissue, which is also a role of which also is attributed to MET, and this MET inhibitor induced edema, which may not be immediately symptomatic, but time to onset may differ amongst the agents. About 8 weeks is what is mentioned for tepotinib, and about 3.5 to half a year for capmatinib. So it is important to identify these subset of patients who do develop edema so that we can appropriately intervene in these patients. It may not be that life-threatening, but we all know that it can negatively impact the quality of life, and therefore special attention needs to be made, especially for elderly, to measure their body weight or the limb circumference and inspect the limb for swelling or skin erosions. And we can these patients can be given a bit of dose reduction the first step dose reduction to about 250 milligram OD once it is resolved. And then, of course, anything which is more than grade 3 may require discontinuation. This is another slide showing the risk of edema, which is associated with advanced age. So dosing reduction, as I mentioned, that it's a once a day convenient oral dosing regimen, and which leads to more patient satisfaction, adherence, and quality of life. General dosing is about 450 milligram, which consists of 2 tablets of 225 each. And the first step dose reduction is to convert it into 1 tablet, that is 225 milligram per day in terms of any adverse events. So has our vision for MET exon 14 become a reality? I believe yes. Testing for MET alteration is recommended by all the important bodies, and the guidelines have incorporated this. And it should be now thereafter be well in time that it should be incorporated in our clinical practice as well. Patients with MET exon 14 skipping mutations, the preferred first-line therapy, subsequent therapy is tepotinib or capmatinib, which is available. Another thing I would like to mention is that we have seen that as per literature, this exon 14 skipping mutations is found in patients with carcinoma sarcoma also. There is carcinoma sarcoma of the lung. So tepotinib offers reliable response in this subset of patients with or without brain metastasis with impressive intracranial activity. It has also an additional dosing convenience, as I brought out earlier. So in all, a compelling argument for inclusion of detection and use of MET inhibitors in our practice. I thank you everyone for a very patient hearing. Thank you very much, Merck, for the slides. And that's all. Over to you, Dubey sir.
Thank you, Rajat. I just have 2 questions for you.
Yes, sir.
That are you doing MET amplification in all your patients of newly diagnosed NSCLC? And second,
yes.
And second question is that if any patient is having positive, comes positive for MET skipping mutation, so will you be more inclined towards starting on the targeted therapy, or you'll consider the targeted therapy in the subsequent setting?
Well, with the availability now with MET inhibitors in exon 14 skipping mutation, definitely the first line preferred therapy would be the targeted therapy. And the question is, of course, by the time we do get the results, sometimes the patients are already started on chemotherapy. So in those cases, then once we get the report, say about maybe a couple of cycles later, we can always convert it into targeted therapy.
So fine, you believe on that whenever driver is there, then you
at least
go ahead with the targeted therapy.
At least in this subset of patients, definitely yes. Maybe not in HER2 or even exon 20 insertion mutations. Maybe we wait up to second line. Okay. But definitely for MET exon 14, EGFR, the standard ones, targeted therapy is the way forward.
Thank you, Rajat. Thanks a lot.
Thank you, sir. Thank you, sir. Thank you.
Next,
Thank
I would like to call my friend, Dr. Manish, who's Senior Consultant Medical and Hemato-Oncology at Action Cancer Institute. So he'll be speaking on translating evidence into practice in stage 3 non-small cell lung cancer. That's a talk on Imfinzi, durvalumab. Dr. Manish, over to you.
Thank you so much, Dr. Dubey. Let me share my screen. So at the outset, I would like to thank the organizers for inviting me here and AstraZeneca for giving me these slides. And I will be speaking on translating evidence into the practice in stage 3 NSCLC. And in particular, I will be discussing about Pacific trial and the real life scenarios in the Pacific trial, the real life studies which have come up. So this is the lung cancer incidence. And the lung cancer is the second most common cancer after lip and oral cavity cancers in India also, at least in males. And the total number of patients which we see in the lung cancer in a year is around 72,000. And the lung cancer deaths around 91.4%. So 91% patient of the lung cancer, they die per year. So how do we manage the unresectable NSCLC stage 3 at the moment? At the moment, this is managed by chemoradiation, either upfront or sequential chemoradiation, and it needs a multidisciplinary team, which consists of pathologist, radiation oncologist, medical oncologist, pulmonologist, and thoracic surgeon. And these are the diagnostic pathways which we all are aware of, which are pulmonary function tests, which we do, bronchoscopy, PET-CT scan, nodal evaluation, and brain MRI. And the treatment remains concurrent chemoradiation versus sequential chemoradiation. Either of them is preferred, but more preference is given to concurrent chemoradiation. But if the patient's PS is not good, then sequential can also be taken in those patients. And this is the chemotherapy regimen which have been used with various radiotherapy techniques in the concurrent fashion. And all of them, they contain platinum-based backbone. Etoposide, cisplatin, vinblastine, cisplatin, pemetrexate, paclitaxel, vinblastine, and so on. And all these regimens, they have been given concurrently with the radiotherapy. And on the right-hand side of the panel, we can see that the median PFS with these concurrent chemotherapy-based regimens is to the tune of 9 to 11 months, not more than that. And even the overall survival also is between 12 to 25 months in various studies. Similarly, if we see the sequential regimen with the help of vinblastine, cisplatin, or paclitaxel carboplatin, you can see that the median PFS is not more than 9-10 months. And similarly, the median overall survival is also not more than 13 or 14 months for these patients who use sequential chemoradiation techniques. So there is a huge unmet need in stage 3 NSCLC, and for quite some time, quite some years, in fact, or a decade or two, we did not find any other thing better than concurrent chemoradiation, which has shown improvement in overall survival for these patients and converted the patients into the chronic disease. So 40% of the patient with concurrent chemoradiation, they have loco-regional recurrences, and 50% patients, they have distant metastasis. Median PFS is 8 to 12 months, as we discussed in the previous slide, and the 5-year overall survival remains very dismal to the tune of approximately 15 to 25%. And it has been tried whether the consolidation chemotherapy improves the survival in these patients after concurrent CTRT. So the consolidation has been given with docetaxel, cisplatin, pemetrexate, or the increase amount of radiation therapy to 74 gray. Patients, they have been given placebo versus gefitinib or cetuximab, but in fact, none of them, they have worked. All of them at the hazard ratio, which was between 0.91 or 1.38, something like that. And no phase 3 study of consolidation with chemotherapy, targeted therapy, or vaccine have demonstrated PFS or overall survival advantage in stage 3 NSCLC. So there is a need of improving survivals in unresectable NSCLC, and concurrent CTRT is the standard of care at the moment. And in those who have marginal performance status, we use sequential chemoradiation, although we know that it is inferior to upfront concurrent chemo-RT. And to improve the prognosis, further strategies like radiation therapy, induction chemotherapy, consolidation chemotherapy, they've been added, but no significant improvement in overall survival has been achieved. So coming on to the talk of Pacific trial. So this is phase 3 randomized double-blind placebo-controlled multi-center international study, which has changed the treatment paradigm in stage 3 NSCLC, unresectable NSCLC. And it is a practice-changing trial, which many of us have adopted in our clinical practice. So patients, they're unresectable stage 3, 18 years or more, and the estimated life expectancy of more than 12 weeks. These patients, they were given chemoradiation therapy, and within 42 days of the chemoradiation therapy, these patients, they were randomized in 2:1 fashion to durvalumab 10 milligram per kg Q2 weekly for up to 12 months versus placebo for the same duration. And the primary endpoints were progression-free survival and overall survival. And the secondary endpoints were overall response rate, duration of response, and safety and tolerability. So these were the baseline clinical characteristic of the patient, median age being around 64, more males were there. Asian population was also represented in this clinical trial. 25% of the patients, they were Asian, 70% were white. Similarly, we can see here that few of the patients, they were EGFR mutant. 6.1% patients, they were EGFR mutant in this subgroup. PD-L1 expression less than 25% or more than 25%, around 39% patients and 24% patients respectively. One of the very important point of interest is those patients who received sequential versus concurrent chemoradiation. So 25% patient, they received induction chemotherapy, while 99% patient, they received concurrent chemotherapy with radiation therapy. So most of the patients received at least minimum of 2 or more overlapping cycles of platinum-based chemotherapy with concurrent radiation therapy. Total number of patients who received this were 711, and 199 patient, that is 26.8% patient, they had also received induction chemotherapy prior to the start of the treatment. And this is the updated 5-year overall survival analysis for intent to treat population, and these we can see the nice separation of the curves from the beginning itself. And the median overall survival for these patients in the durvalumab arm is 47.5 months versus 29.1 months in the placebo. And 5-year overall survival, you can see it is to the tune of 42.9% versus 33% patient in the placebo group. So approximately a gain of 10% probability of overall survival in patients who have received durvalumab. And similarly, you can see that updated progression-free survival. These are the result of 5-year, and the durvalumab, the overall median duration, median PFS is 16.9 months, and for placebo it is 5.6 months. We can see that it is almost triple, and almost 1/3 of the patient, that is 33% patient, they were alive as well as progression-free in those who received durvalumab versus 19% patient in the placebo arm. So this is the first and only approved IO to show sustained and durable PFS as well as overall survival, and 33% benefit at 5-year in progression-free survival. And overall survival in the pre-specified subgroup, almost all of the subgroup, they received benefit. So there was none of the subgroup which did not receive benefit irrespective of PD-L1 status, EGFR, age, sex, disease stage, that is stage 3A or 3B, squamous or adenocarcinoma histology, and similar were the results in the pre-specified analysis in the PFS as well. So first subsequent therapy after discontinuation of durvalumab, what did the patient receive? 41% patients in the durvalumab arm and 54% patients in the placebo arm received subsequent disease-related anti-cancer therapy. And systemic therapy administered with or without radiation were most common for subsequent anti-cancer therapy in both durvalumab and the placebo arm. What we usually do for our patient. So one of the important thing in this clinical trial was the pattern of disease progression. So 45% of the patients in the durvalumab arm versus 64% patients in the placebo arm, they progressed. The reduced rate of first progression is there, and you can see that intrathoracic progression is less in the placebo, and extrathoracic progression, they are more in placebo. While intrathoracic progression is more in durvalumab arm as compared to the placebo arm. So intrathoracic progression were 80% versus 74% in the placebo arm. And this is the time to intrathoracic progression. Time to intrathoracic progression was also significantly better in the durvalumab arm, 9.2 month median in the placebo arm. And you can see the hazard ratio being 0.55. So there were some safety concerns. The grade 3 and 4 adverse events, they were recorded in 30.5% patient, grade 5 in 4.4% patients. And this led to the treatment discontinuation 15% of the patient, while on the right-hand side, you can see that the placebo was also discontinued in 9.8% patient. Grade 3 or 4 pneumonitis happened in 3.6% patient, while 3% patient, they had grade 3 pneumonitis in the placebo arm. And adverse event, which are grade 1 or 2, were seen in 56% patient. But the important thing, the side effects of the adverse event based upon the time from the radiation. So those patients who received durvalumab in less than 14 days versus more than 14 days, the any grade pneumonitis or radiation pneumonitis were more common in those who received durvalumab within first 14 days of the treatment. 40% patient had radiation pneumonitis in those who received in less than 14 days, while 32% patient had radiation pneumonitis if they received durvalumab in more than 14 days. So coming on to the few real-world studies, this is a Pacific R study performed across 10 different countries with 1,100 patients and started in September 2017. And we have now long-term OS with this study. These were the patient and disease characteristics. Majority of the patients, they were less than 75 years of age, and 15% of the patients received sequential chemotherapy in these this Pacific R trial. And overall survival, you can see that at 3 years was 63.2%. So more than 60% patients, they were estimated to be alive at 3 years, and OS was around 66% for 3 years versus 61.8%. So if the overall survival also depended upon the treatment start from the end of radiation. So those patients who received durvalumab within 42 days, the 3-year overall survival rate was 66%. And those who received it in more than 42 days, it was 61.8%. Similarly, PFS was 24.1 month, and more than 40% of the patients, they were estimated to be alive and progression-free at 3 years. And like overall survival, the similar outcome was seen in 3-year PFS rates if the durvalumab was given within 42 days or more than 42 days. So it was 45% versus 40%. So we have to be clear that the durvalumab has to be started within the stipulated time as it was done in the clinical trial. The outcomes by CRT type. So few of the patients, they had received concurrent, while few of the patients, they received sequential. The 3-year overall survival rate was better if patient had received concurrent CTRT, that is 64.8% versus 57.9% in the sequential arm. Comparison with the clinical trial data of the PDL1 status. The PDL1 status more than 1%, the 3-year overall survival rates were more in patients as compared to the Pacific trial. And similarly, for less than 1% also, 3-year overall survival rates, they were better in the Pacific arm, Pacific R arm versus Pacific arm in the PDL1 less than 1%. Safety outcome, pneumonitis was important adverse event, and you can see that moderate pneumonitis were reported in 8.4% patient here in this real world study, and severe event they were reported in 2.9% patient, and life-threatening or fatal event they were recorded in 5 patient, and no new adverse event was recorded apart from those that have been recorded in specific trial. And this is another study, which is a real world study. The real world outcome of durvalumab maintenance in veteran with stage 3 NSCLC. The trial schema was similar. Stage 3 NSCLC recruited in cohort 1 to durvalumab after chemoradiation, and cohort 2 concurrent CTRT alone. Most of the median age was 68 years. Most of the patient, they were current or former smoker, and 41% patient had adenocarcinoma histology and 50% had squamous histology. Cohort 1 had higher rates of severe comorbidity. So these were the patients who had received durvalumab. And you can see that durvalumab significantly increased median progression-free survival from 9.6 months to 16.9 months. And median overall survival also improved from 19.2 months versus 34.7 months. So quickly going through the conclusion, I think I'm running short in time. Median overall survival 47.5 months versus 29.1 month, and median PFS 16.9 months versus 5.6 months with the durvalumab after concurrent CTRT. Overall survival and progression-free survival improved across all pre-specified subgroups. In 5-year OS, 42.9% patient randomized durvalumab arm remained alive at 5 years, and 1/3 of the patient, that is 33% patient, they demonstrated overall survival benefit as well as they remained progression-free in the Pacific regimen. Tolerability profile was acceptable. Patient receiving durvalumab had lower incidence of new lesion, including new brain metastasis, and these outcomes they support the use of durvalumab after.
Thank you, Manish. Just we have a very small panel discussion also on this topic only, but I would like to ask you one question. Like if your patient is EGFR mutated and stage 3, and you are given CTRT, patient has residual disease, will you be more inclined toward using the osimertinib as the therapy, although we don't have such data, or you'll still go ahead with durvalumab?
So few of the patients in this clinical trial, around 6% patient, they had the EGFR mutation, and they did not do well as the other population. And to give this answer, I think we have another trial, LAURA time period. I think the Pacific trial remains in place for these patients.
Okay. Thank you, Manish. Thanks a lot.
Thank you so much.
Next, I would be requesting Dr. Ankit, who is a medical oncologist and hemato-oncologist from Dehradun. He'll be speaking on the role of osimertinib in early stage post-resectable lung cancer, that is ADAURA study. Dr. Ankit, over to you. Thanks.
Hi, good evening, everyone. Am I audible and my screen visible?
Yes, very well.
Okay. So at the outset, I would like to thank Dr. B.N. Kapoor and Dr. A.P. Dubey, sir, for organizing this event, and AstraZeneca for considering me. So today I'll be discussing about the updated results of ADAURA trial, that is the use of osimertinib as adjuvant therapy in patients with resected EGFR mutated stage 1B to 3A non-small cell lung cancer. So we all have seen our ADAURA trial. We all know that for the last 3 years, it has created a lot of buzz, and it is a phase 3 study in which patients from stage 1B to stage 3A are completely resectable non-small cell lung cancer with or without adjuvant chemotherapy was included. These were the inclusion criteria, and it was stratified on the basis of age, EGFR type of mutation, and race, and randomized in 1:1 ratio with osimertinib 80 mg once OD versus placebo. So the primary endpoint was was presented in 2020, and it created a lot of buzz. It was the DFS by investigation assessment in stage 2 and 3A patients, and it was a superiority design with a hazard ratio cutoff of 0.7. Whereas there were a few other secondary endpoints like DFS in the overall population, DFS at 2, 3, and 4, 5 years, and overall survival along with safety and health related and quality of life data. So these were the first DFS curves which we have seen in 2020, and it created a lot of noise. Everyone was discussing and also divided the oncology community into two, whether it is practice changing or we have to wait for overall survivors. So the first one on the left is the DFS curve in stage 2 and 3A, which was the primary endpoint of the study. And at 3 years, it has shown that a hazard ratio of 0.17, which was very significant, as and the DFS percentage was 78 versus 28% as compared to the placebo. Whereas if you see in the overall population, there also it was quite stark, and there was a significant difference between the disease-free survival at 3 years. When we look on the overall population, the baseline characteristics were well balanced between age, sex, smoking history, whether it was race, WHO performance status. In terms of staging, it was also restaged with the AIDS edition as well. It was equally divided 1/3 of stage 1A, 1, 2, and 3 in each arm. And according to the histology, 96% patients in both arms were adenocarcinoma. Exon 19 deletion was slightly higher, 55% as compared to L858R, that was 45%. And adjuvant chemo in both the arms were used in 60% of the patient, and 40% has not received any sort of adjuvant chemotherapy. So this is the updated DFS curve, which we have seen in 2022, that is 2 years later. And it has, in this, we can see that at 4 years also, the DFS is quite significantly better. That is 70% in the osimertinib arm as compared to 29% in the placebo arm, with a hazard ratio of 0.23. So even after stopping the drug at 3 years, when we have seen at 4th year, and in future we'll see at 5 years along with OS, so still the hazard ratio is very good, and the difference between the curves is maintained even at 4 years. Similarly, if we see in the overall population, that is including the stage 1B also along with stage 2 and stage 3 disease, the difference is very well maintained, although the quantum of the benefit was slightly lesser as compared to stage 2 and stage 3, but still the hazard ratio is 0.27, which is also very good. And the DFS in the overall population at 4 years was 73% versus 38%. When we talk about the subgroup, pre-specific subgroup analysis, we can see that in overall population as well as stratified according to age, sex, smoking history, race, stage, or EGFR mutation, and also with the adjuvant chemotherapy, we can see that all the curves have been favoring the treatment with adjuvant osimertinib as compared to the placebo. When we see the DFS curves of the updates according to the stage, we can see that the quantum of benefit is more in higher stages. That is, the stage 3 is the stage which has been benefited the most as compared to stage 2, and benefit is little in stage 1B. Similarly, when we stratified according to the HSCC 8th edition, similar results were seen and replicated, and the quantum of benefit still remained according to that staging system also in higher stages, with a hazard ratio of 0.44 in 1B, 0.33 in stage 2, and 0.22 in stage 3A. So now look at the patterns of the disease recurrence in overall populations. Although the pattern of recurrence remained the same, that is, when we see the osimertinib arm, the pattern of recurrence, the most common site were lung, that is the 12%, followed by lymph node 6%, and the CNS 6%. And similarly, in placebo arm, also these three were the most common site. But the numbers, that is the incidence of the recurrence, was very, very less as compared to the osimertinib arm. So the most important thing is that what is the CNS DFS, that is CNS recurrence. When we see the updated CNS DFS in patients with the selected, that is the stage 2 or 3A disease, we have seen that overall 63 patients have CNS DFS events, that is the recurrence in the CNS. And in that, osimertinib had the patient on osimertinib had 22 patients were there who had CNS failure, whereas in comparison, the placebo arm, it was 41. So only 3 patients, that were 14% on treatment at the time of CNS recurrence with osimertinib versus 71 in the placebo. So this difference was quite important because the pattern of failure and the quality of life is defined by these organs. And here, if we can see that although the median CNS DFS was not reached in both arms, but the hazard ratio calculated at the time of maturity was 0.24. So we can clearly conclude that the CNS failure rates were quite less and significantly lesser in the osimertinib arm as compared to the placebo. Similarly, we can see that conditional probability of the CNS and non-CNS recurrence in patient with this stage 2 and stage 3, there was significantly lesser. You can see the graph that the curve in the placebo arm was significantly greater. The difference is very much. Whereas in the osimertinib arm, the difference is very less. That is, the recurrences in the CNS are significantly lesser as compared to the placebo arm. So these were the main two differences. And when we see the summary, that is the safety of the drug, we can see that any adverse effects were comparatively similar. We had 98 events in the osimertinib arm, whereas 90 in the placebo. So there hardly any difference. In terms of grade 3 or more adverse events, there was slightly more in the osimertinib, which was well accepted, and it was 23 in the osimertinib versus 14 in the placebo arm. And in terms of death, if we talk about that as a grade 5 adverse effect, it was similar in both the groups. And any serious adverse effect was also comparable. They were not statistically significant. And AE leading to discontinuation was slightly higher in the osimertinib arm. That is, it was 13% in the osimertinib versus 3 in the placebo. Dose reductions were also slightly higher because of grade 2 and grade 3 side effects. That is 12% in the osimertinib versus 1% in the placebo. And these were the major differences, but no significantly new safety signal were observed as compared to the primary analysis or what we see in a routine practice. If you see the what all the side effects, if you see the common and the percentage wise, what are the most common side effects, then we can see that diarrhea being the most common, followed by skin changes, nail changes, that paronychia, pruritus, and cough. The more important one was like interstitial lung disease. 3% of the patient in the osimertinib arm has been reported to have ILD, although there was no significant morbidity or death due to that. And the second one was QTC prolongation, which was reported in 9% patients with the osimertinib arm. So these two are the life-threatening or serious adverse event which should be watched off when we use osimertinib in our clinical practice. So with this, I would like to conclude that the updated DFS analysis of the osimertinib versus placebo in the ADAURA has patients will have been followed for further 2 more years and opportunity to complete 3 years of the complete planned treatment. And overall, there was a 77% reduction in the disease recurrence or death or with adjuvant osimertinib as compared to the placebo. We have already seen the hazard ratio, which was strikingly different in stage 2 and stage 3 population. The median DFS was almost 3 times higher, that is 21.9 months versus 55.8 months as compared to placebo. And there was a 73% reduction in the risk of the disease recurrence or death with the adjuvant use of adjuvant osimertinib in the overall population. And it was seen regardless of use of adjuvant chemotherapy, whether chemotherapy was used or not. And DFS benefit was also seen in all the stages, although the quantum of benefit was more in higher stages. And it also demonstrated a clinically meaningful, significantly improvement in CNS DFS, that is with a hazard ratio of 0.24, and with no new safety signal. And the median total duration of exposure to osimertinib after completing the when all the patients have completed the treatment was 35.8 months. So these updated data reinforce us to use adjuvant osimertinib as the standard of care in patients with EGFR stage 1B to 3A non-small cell lung cancer after complete tumor resection with or without adjuvant chemotherapy. Thank you.
Thank you, Ankit. Very crisp and that was very charismatic. This one outcome by osimertinib. But I would like to ask one question, that if the patient has the similar outcomes were seen in patient with uncommon EGFR mutations vis-a-vis common EGFR mutations, any such stratification been done?
No. So only deletion 19 and L858R was included in the study. They have not included uncommon mutations in the trial.
So if suppose in your patient some uncommon mutations are being detected, so will you be more inclined towards using afatinib, or still you'll, based on just this trial, though it didn't include the uncommon mutation, you'll go ahead with osimertinib?
So as of now, for uncommon mutations, I'm still using afatinib. And depending on the tolerance, one or two of my patients have not tolerated afatinib well, and then I have to switch to osimertinib in that case. But otherwise, first preference in uncommon mutation is still afatinib.
Fair. So thank you, Ankit. So next, I would like to call my very good friend of mine, that Dr. Shiv Shankar, who will be speaking on a very important, that I should say, that paramount topic, which should have been the first topic today, but because of certain commitments of my prior speakers, so this topic was pushed down. So sorry, Shiva, but anyways, you have to be here till the end of the CME. So I would like to request you to go ahead with your molecular profiling in lung cancer. Thank you.
Thank you, Dubey sir, and thank you, B.N. Kapoor sir, for having me here. It's definitely a great pleasure to discuss these very important topics. As Dubey sir has already clearly mentioned, molecular biomarking is already in a clinical practice. We are all well aware. So we know that lung cancer in India, as per Globocan 2020, it is fourth most common cancer among both sexes and second in males, next only to head and neck squamous cell carcinoma. If you look at the mortality, again, it is the fourth most common cancer. So in lung cancer, if you look at a decade earlier, it was just adeno and squamous cell carcinoma, but now we see that it is not a single entity. It is a group, it is heterogeneous diseases. That this pie diagram shows that it has been sliced so many times that there are multiple drivers which drive. Roughly around 50% of non-squamous non-small cell lung cancer harbor one or the other kind of these oncogenes, which either have a already FDA approved treatment or the drugs are in clinical trial. In remaining 50%, we do call them as a genetically complex tumors. These oncodicted tumors, we call them genetically simple tumors because only one or two of these mutations drive their cell proliferation and cell survival. In the remaining 50%, it is usually genetically complex. They have a multiple complex mutations, or in some cases, we are not able to identify mutations. So why do we need these biomarkers for treatment? Definitely, precision medicine is a very much reality in lung cancer, as seen in the previous slide. There are multiple targets available. And we know that with the EGFR targeted therapy, initially all kinds of adenocarcinoma based on either sex or smoking status, when we try to recruit them, patients for EGFR target, we did not achieve that much of efficacy. But when we had a predictive marker of EGFR mutation, the efficacy went up. So we need a marker to choose various treatment options available. Not only delays the treatment, right treatment options, and also it may lead to unnecessary harm if you do not start treating based on biomarkers. This is a publication which was published in JAMA in 2019. This was probably study started way back in probably a decade back. That time only the studies with available few oncogene drivers, the study has clearly shown that there is a definite survival advantage if you go a target driver, molecular marker based therapy. But if you conduct this study in the 2023, probably these curves will be very much separated. So how do we approach a advanced non-small cell, advanced lung cancer? Probably first, based on histology, we will divide into small and non-small. In small cell, as of now, we do not have much of marker. In non-small cell, again, further, we will be dividing into squamous and non-squamous. In non-squamous histology, we have a array of molecular markers along with PD-L1 testing. In squamous, PD-L1 testing is compulsory. Apart from that, the narrative in last 2 to 3 years, it is changing that we tend to do these molecular analysis even in the squamous cell histology. This is also very well illustrated in NCCN 2023, that if histology is adeno, a large cell, or non-small cell, we need to do all these kinds of molecular analysis along with PD-L1 testing. Even in the squamous cell carcinoma, they suggest that consider molecular testing for EGFR, ALK, KRAS, ROS1, BRAF, NTRK, MET exon 14 skipping, RET and HER2 along with PD-L1 testing. So if you choose a tissue-based biopsy-based method, then what are the available methodologies to look for these particular molecular biomarkers? Or we have NGS, either DNA-based or RNA-based NGS, PCR methods, IHC, FISH. So we have so many platforms to choose. We have so many markers. So how do we sequence, or how do we go ahead, which one to choose? Apart from tissue-based this diagnostic modality, we also have something called as liquid biopsy, that is ctDNA-based. ctDNA-based methods can also be used for diagnosis and for treatment allocation. And also CT-based, this liquid biopsy also helps in not only in diagnosis and treatment allocation, it may also help in monitoring the disease progression. ctDNA quantitative level can be used to either to detect the residual disease or monitor the responses, whether they are progressing or they are responding. And also ctDNA helps in understanding the heterogeneity of the tissue. And also particularly when tissue is an issue, ctDNA acts as a complementary and helps to pick up the molecular markers. So some of the advantages of liquid biopsy compared to tissue biopsy is simpler acquisition, just a blood draw, and also repeat sampling. If you go for a liquid biopsy, we can monitor over a period of time and also look for is there any upcoming resistance mechanism. But some of the drawbacks are it does not have a correlation with what kind of histology the underlying histology might be, and also sensitivity assess required for liquid biopsy is very, very sensitive methods are required, and there are not very well established guidelines for analytical standardization. And evidence for clinical utility is very well available for tissue-based. For liquid biopsy-based clinical utility, it is evolving, and rapidly increasing evidence is coming up even for liquid biopsy-based treatment allocations. So another important question, apart from choosing these platforms, is how do we plan these tests? Should we go for a single in sequence manner, or we test for a multiple test to simultaneously, that is single gene testing or an NGS, which includes broad complex array of testings? So what are some of the advantage or disadvantage if you go for NGS? Definitely the disadvantages with NGS are cost. Cost is relatively higher. If, for example, if somebody has a EGFR mutation and if he is just undergone a PCR, or if he has to undergo NGS, the cost is definitely more for that particular patient. But if you look at the number of tests together, probably the NGS cost will come down. If you look at the overall population, the cost of NGS may not be higher. And another important problem with NGS is the turnaround time. The turnaround time for PCR or IHC is 2 to 5 days, but turnaround time is 2 to 3 weeks for NGS. But with the availability of array of markers, we cannot keep on doing one test after one test. So definitely multiplex testing is certainly the way to go. The most of the guidelines do also recommend broad complex assay like NGS. And since we have a very big shopping list, so probably NGS is a good solution. Though it is relatively costly, if you look for all the tests together, definitely it is more practicable. And some of the issues maybe with NGS is mutations may be very well picked on DNA-based NGS, but fusions may be missed for that RNA-based NGS. And for gene copy number NGS may not be that sensitive compared to FISH or ISH-based methodologies. And some of the protein expressions, they are not cannot be understood based on NGS, like either PDL1 expression. So if you group some of the molecular markers, we have some molecular markers like mutations. They are either insertion or deletions. These are EGFR, KRAS, BRAF, MET exon 14 skipping R2. They are very well picked on DNA-based NGS. If you look for fusions, all RAS1 fusions, NTRK fusions, RET fusions, and now upcoming another fusion marker is NRG1. These markers are very well picked on RNA-based NGS. For gene copy member, NGS is not a very sensitive method. For them, either FISH or SISH are better methodology. Definitely for protein expression, still IHC is the gold standard. So in if you look at the lung cancer, we have these markers. For in the EGFR alone, we have a classical EGFR that is either in exon 19 or 21, that is del 19 L858R. For that, PCR or NGS are commonly used methodology. For uncommon mutations like exon 20 insertion, now we have a second line treatment options like bosutinib, amivantanib. They can also be picked up either based on NGS or PCR based methods. Some of the uncommon mutations again can be picked up in the NGS. Usually we use afatinib or osimertinib in those. ALK and ROS1, we know that both can be detected either on IHC or on FISH or on NGS. Other rare mutations like though KRAS is a very common mutation seen roughly in 30% of the adenocarcinoma. Unlike EGFR ALK ROS, which are seen in never smokers, KRAS mutations are most commonly seen in the smokers, and among various KRAS mutations, it is KRAS commonly mutation seen in the codon 12, and among them G12C variant, which is seen in roughly around 13% of the patients. Now we have a second line treatment options like sotorasib, which is currently approved for this particular mutation. Apart from KRAS, another mutation which is commonly seen in the smokers, unlike other mutations, is BRAF, which is again, it has a very varied different kind of mutations. Among BRAF mutations, V600E mutations constitutes roughly more than 50% of BRAF mutations, which is seen in 1 to 5% of patients, most commonly in adenocarcinoma, and is commonly seen in smokers. And again, we have an approved treatment for BRAF inhibitors. And CMET, we had seen previously that MET exon 14 skipping, not MET amplification. They are two different entities. For MET exon 14 skipping, we have a first line therapy, which is seen in 3 to 4% of non-squamous non-small cell lung cancer. And if they have a sarcomatoid histology, this non-small cell lung cancer has a sarcomatoid histology, then the harboring of this MET exon 14 skipping increases. And we usually go for NGS, DNA NGS, but if you go for RNA based NGS, the chances of picking even goes up. So other mutations like RET receptor mutations, again, RET mutations are RET fusions, which can be either picked up based on the either FISH or on the NGS. Again, for RET also, we have a upfront first line therapies. The other rare mutations, NTRK mutations, they are not commonly seen in NSCLC. But again, for NTRK fusions, we have different methodologies. Either we can go for IHC or we can go for NGS. If it is a rare mutation, usually we do screen them with a IHC. If they're positive, then we go for a single based. But in lung cancer, anyway, we are directly going for a broad complex based assess. So we directly do NGS. And if there are a characteristic mutations, fusions, then we use that is diagnostic. If there are novel rearrangements, then we need to confirm them with a IHC also. So these are various methodologies for NTRK, IHC, FISH, NGS. Each have their own advantages and disadvantages in terms of sensitivity, specificity, and turnaround time. So another mutation, that is HER2 mutation. It is not HER2 expression like breast cancer. It is a HER2 mutation, which is seen in roughly in 3 to 5% of the 5% of cases. Mostly HER2 mutations are seen in exon 20 in-frame insertions. Again, we have a later line therapies for HER2 mutated non-small cell lung cancer. If you look for HER2 expression, they are commonly seen in SCLC. If you look for 3+ HER2, which is seen roughly around 30% of cases. Apart from these biomarkers, we also look for this molecular markers. We also look for PD-L1. In PD-L1, we have another complexity. Which kind of platform do we use? Because each drug is FDA has approved different platform for each drug, and the trials also used those particular platforms. For pembrolizumab 22C3, for durvalumab SP263, for atezolizumab SP142, for nivolumab 28-8. However, in the blueprint trial, apart from SP142, the correlation between the remaining three are very much correlated. So probably either 263 or 22C3 can be interchanged. So apart from PD-L1, we have also other markers like TMB, MSA high, probably LAG3 is coming up to predict the role of immunotherapy in NSCLC. So to conclude my talk, definitely biomarker-based treatment option is a very much reality. And since we have a wide array of molecular markers to pick up, broad-based panel like NGS should be the panel should be the commonly used, which is endorsed by multiple guidelines. And if sample, if tissue is an issue, then definitely, I mean, liquid biopsies may have a complementary role. But the issue with this NGS or NGS is the turnaround time. Usually, it may takes up to 2 weeks. And also another idea that may we get in NGS, not only the markers which may predict that treatment, also we may find some interesting information regarding the markers of resistance also with this broad-based panel. With this, I conclude my talk. Thank you.
Thank you, Shiv Shankar, because I guess you made the slides by your own. So that was a very commendable effort by you. I would like to ask that how many patients you are able to like convince this NGS testing rather than a single gene, sequential single gene limited testing?
Sir, basically at RGCA, what we have is this, whatever the molecular markers I depicted, we have that smart panel, smart lung panel. So it costs somewhere around 25,000. So majority of our patients are going for that. Sir. Okay. So roughly around 60 to 70% of our patients are going for NGS.
And what is the TAT? TAT?
TAT is 2 weeks.
2 weeks. And you are doing it for both adeno and squamous, both?
I do advise, sir. But if patients is interested, we are even not doing in squamous. Probably nowadays, I mean, if I have to pick one number, probably 20% of squamous cell advanced are going for 10. NGS.
Yeah. Thank you, Shiva. Now I would like to invite Dr. Novak for with Dr. Novak. I guess we can like postpone his talk after Dr. Kaushik. So I request Dr. Kaushik, who is a very good friend of mine, posted at INHS Ashwini, to go ahead with his talk on BRAF inhibitors in metastatic CLL. Dr. Kaushik, over to you.
Thank you, sir. Is my screen visible, sir?
Yes, very well.
Thank you, sir. At the outset, I would like to thank General Kapoor, sir, and Dubey, sir, and also the organizers for this opportunity. So my talk today will be on the personalized therapy, how to improve the outcomes in patients with BRAF mutated metastatic non-small cell lung cancer. So these are the disclaimers. So the slide support has been from the Novartis.
Can you please make it full?
Is it okay now?
Yes, sir. It's okay.
Thank you. So the objectives of my today's talk would be to understanding the role of BRAF in metastatic non-small cell lung cancer, and to gain some awareness regarding the testing methods, and to diagnose the BRAF positive subset of non-small cell lung cancer, and some reviewing of the clinical data regarding the dabrafenib and trametinib in this subset. So coming to the BRAF, we know the MAPK pathway. It is the important one of the important signal transfection pathway, which helps in transforming the signal from the growth cell receptors, leading to the cell proliferation. So here, BRAF is the downstream of the KRAS in this pathway, which helps in activating this MAPK and finally the cell proliferation. So the BRAF, various mutations have been seen in these BRAF kinase pathway. And majorly, the studies are from the melanoma, where to the tune of 50 to 60%, the BRAF mutations have been seen, followed by the colorectal and thyroid. And in non-small cell lung cancer per se, the percentage of mutations in BRAF is to the tune of 1 to 4%. And we will be talking in this subset of patients in today's discussion. So these mutations in BRAF results in the uncontrolled signaling by the MAPK pathway. So as I said, it accounts for around 1 to 4% in adenocarcinomas, and the important is that typically do not overlap with other common mutations seen in these subset like ALK, EGFR, or KRAS. And also, in contrast to other driver mutations like EGFR, the patient characteristics are not that well characterized in these BRAF mutated positive subset of patients. They do not correlate with the age, sex, or stage or the smoking status. However, with the data available and with the past studies, it has been seen these mutations are most commonly seen in the female and those with the having history of smoking. So the common mutation is the BRAF V600E. Usually in the domain exon 15, it is present and it occurs in up to the tune of this V600E up to the tune of 50 to 70% of cases. Usually it is caused by the point mutations in BRAF kinase domain where valin is changed to glutamic acid. So coming to the types of mutations other than the V600E, there are other common non-V600E mutation also is present. So here in this one subset of study where we had 1,000 non-small cell lung cancer patient study, it has been seen the BRAF positive was seen in 4% of adenocarcinoma and V600D was positive in 56% of patients and non-V600D, which has been depicted in the slide, is present in 43% of patients with non-V600D mutation. So, and few small studies have shown that in patients with BRAF V600D mutations, it's one of the feature with these patients are usually has been shown to have aggressive tumor, and they usually have a short and median DFS and OS compared to those with wild type BRAF subset of patients when treated with the platinum-based therapy. Also, the outcomes when compared to the V600D and non-V600D, also the PF is a bit of worse in those with patients with V600D in those with when treated with platinum-based chemotherapy. So overall, these BRAF V600D patients usually have an aggressive clinical course, and usually 1/3 of patients in the first line they usually go for only palliative bed supportive care, and remaining who usually receive the first line chemotherapy. Again, second line, majority of them go for only palliative bed supportive care. And present till now, only we had is the doublet chemotherapy was the most common treatment option in these set of patients, and coming to our previous experiences with the targeted therapy and also the previous speakers, what has been taught here, we know that those patients who had driver mutation usually do better with the targeted therapy and you have better OS and better PFS when compared to those without driver mutation when treated with actionable therapy. So, and also the previous speaker have brilliantly depicted about the importance of broad molecular profiling in these set of advanced non-small cell lung cancer patients, and also it has been recommended by the standard ESMO and NCCN guidelines. At least the minimum minimum testing should be required for EGFR, ALK-ROS, and BRAF, and whenever it is possible, we should go ahead with a broad molecular profiling technique using NGS-based platforms. So upfront, the importance of this, the upfront of BRAF testing is one. It helps us to identify the patients who we can be able to treat with the targeted therapy, and these sets being more aggressive therapies, and some targeted therapies have been shown demonstrate clinical efficacy in this set of patients who are V600E typical mutations. So few data, what we have is the phase 2 data still now available for the both darafinib, that is dabrafenib, and next it is trametinib. We'll go ahead with the phase 2 data. So rafinib, dabrafenib is a reversible, selective, potent inhibitor of the RAF kinase, particularly the BRAF V600E and V600K. And trametinib is a reversible, selective inhibitor of the MEK kinase activity. So, what is the importance of combining the dabrafenib and trametinib? So, it has been shown majorly in the melanoma studies and in non-small cell lung cancer studies. So, by combining the BRAF inhibition along with the MEK inhibition, it has been shown to act synergistically inhibit the MEPK pathway and also to delay resistance in those with BRAF inhibitor animal models. Also, this combination will inhibit cancer growth more effectively than monotherapy compared to the monotherapy, which has been shown in advanced melanoma set of patients. So this is the phase 2 study of dabrafenib and trametinib in it is a multi-cohort non-randomized open-label phase 2 study where the patient with stage 4 BRAF V600E positive non-small cell lung cancer with a good performance status of PS02 and those who had no prior treatment were allocated into 3 cohorts: cohort A, cohort B, and cohort C. So here it's important was those patients who were symptomatic, non-stable, and those who had brain mets were excluded from this study. So 3 cohorts were allocated: the cohort A, cohort B, and cohort C. The cohort A, the patients in cohort A were those who had received the previous platinum-based chemotherapy, and they were planned to receive only monotherapy with the dabrafenib. And cohort B, again, they were treated with platinum-based chemotherapy, and they were elected to receive the combination chemotherapy with the dabrafenib and trametinib. And cohort C patients who were treatment-naive patients who had not received any sort of treatment, and they were able to receive the combination therapy with the dabrafenib and trametinib. So the primary endpoint was investigator assessed overall response rate as per the RECIST 1:1 criteria, and also the independent review committee was also used to assess the overall response rate. The secondary endpoints here were PFS, duration of response, overall response, safety profile, and population pharmacokinetics. So coming to the patient characteristics in the cohort A, these were the patient set of cohort where patients had recently received the platinum-based chemotherapy. The median age was around 66 years, equally distributed as per the sex distribution. Majority were whites, and the 22% of patients were Asian, and 2/3 of the patients were either current smokers or former smokers, and majority were adenocarcinomas of 96%. Almost half had received in the second line or third line systemic therapy. In cohort B, again, the median age 64%, and the whites consumed around 86% of patients were whites with good performance status. Majority, almost all, were adenocarcinoma. Again, 3/4 of the patients were smokers, and more than 1/3 received the previous platinum-based chemotherapy. And in cohort C also the same patient characteristics. It was around median age of around 60-65, and all had adenocarcinoma histology, and around 2/3 were around former smokers or current smokers in this set of patients. So this was the summary of the study design. So it was mainly it was a phase the primary endpoint being the investigator ORR, and divided into 3 cohorts: cohort A, B, C, and major of the patients were adenocarcinoma mainly, and they were current or former smokers. So coming to the results, the investigator assessed the efficacy in cohort A set of patients. The cohort A set of patients were previously treated with platinum, and they were treated with monotherapy with the dabrafenib. Here, the overall response rate was seen on the tune of 33%, with the disease control rate of around 58%, and the duration of response, the median duration of response 9.6 months, the median PFS of 5.5 months, and the median OS of 12.7 months with the dabrafenib monotherapy in previously platinum treated subset of patients. Next, coming to the cohort B, where these were the previously treated subset of patients, BRAF V600 mutated, who had received the combination of dabrafenib and trametinib. Here, the investigator, both the investigator assessment and the independent assessment, overall response rate was to the tune of 63%. The disease control rate to the tune of 75 to 80%. The duration of response of median duration of response to 9 months. So here in this waterfall, you can see the cohort B experienced the improved overall response rate to the tune of 63%, and the duration of response was 9 months, both in the investigator and the independent review committee, and the 50% of response were ongoing at the time of data cutoff of this study. So even in the cohort B, the PFS almost it was doubled compared to the PFS in this cohort B who had received the combination therapy. So it was 9.7 months. It was almost doubled. It was 5.5 months in the dabrafenib monotherapy in cohort A patient, and the 6-month PFS was to the tune of 65% in this set of patients. In cohort C, these were the set of patients who were treatment naive and who were received the combination of dabrafenib and trametinib in the treatment-naive set of patients. Again, the overall response rate was the same as in the cohort B, to 64%. The disease control rate was to the tune of 75%. The median duration of response was 10.4 months in the investigator assessment, and the independent assessment to the tune of 15.2 months. So again, the typical overall response rate in this treatment-naive patient to the tune of 64%, and the duration of response was 10.4 months, and the number of patients with confirmed overall response in this set of cohort was to the tune of 64%. Again, the PFS, it was almost doubled compared to the dabrafenib monotherapy, where it was 10.9 months in these set of patients who were treatment naive and received dabrafenib and trametinib, and it was 5.5 months in dabrafenib monotherapy. And in the 6 months, the PFS was to the tune of 72%. So, coming to the efficacy summary overall, the combination therapy was more effective than the dabrafenib monotherapy in previously treated BRAF600E positive patients, with both the overall response rate and the PFS nearly doubling the overall response rate of 33% in dabrafenib monotherapy compared to the tune of 60 to 65% in combination therapy, and PFS 5.5 months in monotherapy, with 10 up to the average 10 months in combination therapy. So coming to the safety profile of this study and monotherapy, the monotherapy set of patients in the cohort A, the safety major common adverse was pyrexia to the tune of 33%, followed by asthenia, hyperkeratosis, some GI toxicity, decreased appetite, and skin toxicity. So, however, in overall in other cohort results in cohort B and the combination therapy, the almost all patients, around 98%, had experienced all grade adverse events, and almost 49% had a grade 3, grade 4 adverse events. Even though 98% experienced all grade adverse events, the discontinuation rate was low, only to the tune of 14%. And in this cohort B patient, again, the most common was pyrexia to the tune of 46%, and only 2% had patient with a grade 3 pyrexia. Serious adverse events were reported in up to the tune of 56%, and only 4% had and those who had 4% had pyrexia, followed by anemia and a bit of confusion state. Now, the importance is of the fatal adverse event, which was seen in the 4% of the study, was considered to be unrelated to the study medication. And in cohort C, also, again, the pyrexia being the most common adverse event, it's seen on 64% of the patients. And also, the one fatal adverse event was seen, was again unrelated to the study population. The major side effect in all three cohorts was pyrexia, followed by skin and as well as GI toxicity. Also, as per the phase 2 study and the experience seen by the investigators, they had proposed how to manage the pyrexia management in these patients who had been treated with the combination therapy. First step was to interrupt the treatment with the dabrafenib and trametinib can be continued with the supportive therapy with the antipyretics and the bilfin or the astrapinophen paracetamol combination. And later, if still non-responsive, a short course of corticosteroid, like this depicted in this slide. In the first event, antipyretic treatment supportive, followed by interruption of the dabrafenib, trametinib can be continued, and once pyrexia has been resolved in the first event, then a gradual restart of dabrafenib can be considered in the same dose level. However, in case of any second event is still recommended to start oral corticosteroids for the minimum of 5 days. And further, if there is any subsequent events of pyrexia, they usually advise to interrupt the dabrafenib and continue the oral corticosteroids in optimal dose with gradual tapering, and restart once the events is settled with the lower doses of dabrafenib. So this is the dose reduction recommendation from the investigators. The dabrafenib starting dose is 150 milligram twice daily, and the trametinib is 2 milligram once daily. The first dose reduction is usually 100 milligram with dabrafenib and 1.5 milligram in trametinib, followed by second dose reduction of 50 milligram and 1 milligram in these two molecules. So usually they are recommended to the trametinib is recommended to be taken at the same time each day, either in the morning dose or evening dose with the dabrafenib, and usually be taken in the empty stomach, either without food, which is 1 hour before or 2 hours after the meal. So overall, the safety profile, the combination therapy was manageable, And the similar experiences was seen in the previous studied melanoma studies. And most common adverse events was pyrexia, GA-related events, and skin reactions. And also the pyrexia was most frequently seen in all cohorts. And in cohort A had 33%, cohort B 46%, and cohort C around to the tune of 64%. And it was manageable with the pyrexia management protocol, which has been advised by the investigators. So based on this, the DCI had approved dabrafenib in combination with trametinib in patients with advanced non-small cell lung cancer with PIRA-V6 and mutation. So this is the basic processing statement of dabrafenib and trametinib. So here I conclude my talk. These are the references. Thank you.
Thank you, Kaushik. In the interest of time and also Dr. Novak waiting since long. Sorry, Novak, to push you back. So I again request you to go ahead with a panel discussion, which will be having two case-based discussions. First will be moderated by Dr. Abhishek, and second will be mine. I request all the panelists, Dr. Hemant, who is a radiation oncologist with me, and Dr. Kaushik, medical oncologist, Dr. Rajesh Nair, and Dr. Deepen, and Dr. Shivshankar. I request all of them to join. And Dr. Abhishek, kindly start with your case, and we'll try to wrap up each case in 15 minutes.
Hi,
Thank
Dr.
you.
Dubey. Thank you for inviting. Thank you, Dr. Kapoor, and thank you, AstraZeneca, for this session. I think in the program it was only Dr. Hemant and your name.
No, but for you have the luxury of
wow.
all styles.
Okay. So I'll just start with sharing my screen. So wonderful to have here, and we'll be discussing a case-based discussion on basically unresectable stage 3 non-small cell lung cancer. And we know that we have a new player in town, durvalumab, and after the result of Pacific trial, we have data to suggest that there are certain subset of patients who are living longer, achieving realistic survival of around 5 years in 40-50% of our patients. So let's start with the case. And so let's say he's Mr. X, a 59-year-old gentleman, smoker. He presented in July with cough and weight loss for the past 3 months. Here's his X-ray that was done outside. You can see that there is a right upper lobe mass. There is no history of any comorbidities. So my question to the panelist is, Dr. Dubey, you can take up the question, like how would you evaluate him?
He's having only this lung mass, and we have
Lung
only
mass,
X-ray.
yes.
So I would just first go ahead with the minimal baseline PET CT.
Okay,
to rule out any distant metastasis.
Yeah, all right. And I think we can see that probably. So yes, we have done a PET CT, and we have found out that okay, it's a malignant appearing mass in the right upper lobe. So what next? Who else are in the panel? I'm sorry,
we have Dr. Hemant, who is the radiation oncologist. We have Dr. Kaushik, Dr. Rajesh.
Okay, Dr. Kaushik can take this question. Dr. Kaushik, are you here, sir? Dr. Rajesh?
We have Dr. Hemant.
Hello,
yes,
am I audible, sir?
Yeah, Dr. Rajesh, you're audible.
Yeah, for complete staging, I would like to perform PET CT.
Yes.
And preferably CNS also should be evaluated by MRI. Okay. And then tissue, if tissue is not done, then biopsy.
So coming back to Dr. Dubey again, okay, so it comes out to be, say, adenocarcinoma. So what additional investigation you will like to have here?
If it comes to adenocarcinoma, I'll just go at first. tumor board discussion that.
So he has a basically right upper lobe mass. He has some lymph node in the mediastinal. No extracranial disease in the PET scan, as you had advised for doing the PET scan. So any other investigation at this point you would like to do?
No, that I would like to take opinion from our oncosurgeons that how is the what is the pattern like? How is the mass resectable or not?
Okay.
That way, I would like to go ahead with the tumor board discussion first.
Okay. Any other, like there are now plethora of molecular testing available to us?
Yeah, that molecular profiling of the lung cancer along with biopsy will be surely done for this patient. But apart from me, that will be a second step after the resectability that I'll be testing on the resectable sample.
As Dr. Rajesh had rightly pointed out, it's a reasonably good-sized mass with mediastinal lymph node. So yes, MRI brain to rule out any brain mets. Histopathology was done, which was adenocarcinoma lung. I was also tested for PDL1, which was 20%, and EGFR was negative here. So it was a T3N2 disease. So Dr. Hemant, would you like how should we go about it? Would you also like to involve your surgeon in the discussion at this point?
Yeah, surely. First, I would like to thank Dr. A.P. Dubey sir for inviting me. And secondly, I would like to thank the organizing committee. So in some T3N2 cases, there are some cases who are resectable. So for that, we have to go upfront mediastinoscopy and or EBUS to rule out, for proper staging of mediastinal lymph node. Since this has been right upper lung tumor and the size is around 5.3 centimeter. So surgical opinion should be taken in this case if this tumor is resectable with adequate lymph node dissection.
So do we have any surgeon in the panel, sir? Dr.
Yes.
Dubey?
No, we don't have any surgeon.
Okay, so anything very rightly pointed out by that we should ideally do a mediastinal staging because radiological N2 might still be N3, and whatever you're saying, particularly for the central nodal disease, you need to prove it, what it is. So let's say it's a T3N2 disease and it is, your surgeon says that it is unresectable. So Dr. Hemant,
yes, sir.
So the patient is sitting in your OPD, what will be your opinion to him?
So if the surgeon say that the tumor is unresectable.
3B.
Sorry, sir?
It's 3B, staging 3B.
Yeah, 3B. So according to RTOG 0617 trial, and there is one also meta-analysis, which say in that case unresectable, say in such as this case unresectable case, we should go directly at definitive concurrent chemoradiotherapy and followed by durvalumab specific trial. So if the tumor is non-progressive while on concurrent chemoradiotherapy, so after therapy, right from first day to any time between 42 days, you can start durvalumab for 1 year. So treatment will be. My advice to that patient will be definitive concurrent chemoradiotherapy.
So Dr. Dubey, at this point, what are the important decision making when you are deciding the patient for any definitive therapy for this patient? And what all points you involve in the discussion?
See, now it is stage 3B, T3N2 disease. N2 disease are mostly unresectable, but already Dr. Hemant has very clearly specified the role of oncosurgeons in few N2 disease. Secondly, the performance status of the patient is very much important, whether the patient is able to receive the concurrent radio and chemotherapy, or we should go ahead with the sequential. Radiation followed by chemotherapy, although the concurrent remains the best. So, and the other comorbidities remains talking about all these things remains the point of discussion at this point.
Any other investigation you do to assess the patient's fitness? Because I recently faced this challenge. That is why I'm asking this question. that we had a stage 3B disease. So any other investigation before
And-
initiating the patient on chemotherapy apart
It's a
from
stage 3 disease, so I'll be surely doing an MRI. But yeah, PFT, if it has to be
Yes,
done,
very
I'll
good.
not go ahead with PFT because PFT is generally being done for patients who are we are planning for surgery. But I don't know if that's subjective choice that how we can go ahead with.
Actually, I had a patient who had a bronchiectasis. He was a coal mine worker, and he had extensive bronchiectatic changes in his lung. We did a PFT, very bad PFT, and my radiation oncologist was not very keen on radiating him because. So, what are the factors which you assess while? Like whenever you are planning the patient on radiation therapy, Dr. Hemant, it is for you that which are like predictors of toxicity or long-term toxicities whenever you are giving radiation, because we know that lung is very sensitive to radiation, particularly with durvalumab. A lot of pneumonitis is happening in patients who are going to live longer.
Right, sir. Right. So first, I would like to say that in this case, the case summary says that there is no.
No, there is no.
There is no comorbidity.
Yeah.
So I would like to assess, like I would like to assess the history, like any previous history of interstitial lung disease, or any previous history of cardiac disease, or any previous history of COPD, all these things. And then I will also do a PFT to assess the pulmonary function test. The lung volume, and then after that, like. And yes, and of course, previous cardiac history I would like to assess at this point of time. So if if there is any previous history of interstitial lung disease or COPD, then our radiation target volume and modality of delivering of treatment like radiation, that will be changed. That will be I will adopt a better like tumor control motion management technique, like IMRT with IGRT or VMET technique. And I would also advise the patient to go for, if the patient can afford. So I will advise the patient for proton radiotherapy if there is any like severe interstitial lung disease or severe comorbidity.
So any objective criteria, just for my clarity, I don't know about this, any objective criteria that you decide prior to radiation, which predicts that, okay, this patient is going to do poorly. Like for operability, we have some criteria based on PFT. So
Yes,
is
sir.
there anything in radiation also?
So if like DLCO is less than 40% and FEV1 is less than 80%, in that case, I would like to change the conventional radiotherapy into some other modality.
But in all COPD patients,
Yes,
FEV1 will be less than 80%.
Not in all COPD cases. If there is severe COPD or interstitial lung disease where the lung volume has been severely compromised.
Sorry, AstraZeneca, I know it's a durvalumab system, but I think this is probably more practical challenges we face when we are managing our patients. Anyways, so basically he was right lung non-small cell lung cancer, stage 3B, adenocarcinoma, EGFR was done for I don't know what reason. PDL1 was positive. So Dr. Rajesh, are you routinely doing PDL1 in any of your stage 3 patients? In unresectable non-small cell lung cancer patients?
Routinely, we don't do, sir.
Okay.
Otherwise, for post CCRT consolidation, we can do. So PDL1 positive patients, they afford maximum benefit. So for that we can do. Otherwise, for here in our institute, routinely we don't do PDL1.
All right. Okay. Yes. So for I know the approval for durvalumab that we'll be talking about, it is irrespective of the PDL1. But yes, a lot of our patients are not affordable for the drug. And if you have to do a shared decision making, and if you want to find out that which are probably the best patients who are going to benefit, then you can probably take a decision based on PDL1 positivity. So moving on. So basically, the treatment options that Dr. Hemant has very rightly said that we should plan a concurrent chemotherapy. So Dr. Rajesh, again, what chemotherapy regime you use when you are using concurrent chemoradiation? Or is there, and Dr. Dubey, if you can take that, if there is any role for induction chemotherapy here, induction followed by CTRT or induction followed by anything else?
No, actually, induction chemotherapy has not shown any significant benefit in survival. I'll go ahead with concurrent and taxane plus platinum-based concurrent chemotherapy will be my choice of regimen.
So there are still some people who are doing induction chemotherapy. If you see the Pacific trial also, there are also around 26%
Yes.
patient had received
1/4
induction
patient.
chemotherapy. So what could be a rationale for that? Probably delayed radiation planning. Your patient is very symptomatic. You want to give treatment relief. Maybe some of those unusual conditions.
Maybe I guess Dr. Hemant might be able to give the clarity to the answer, because might be a very large radiation field will be required in that those
Yes,
patients with
that
large
could be
tumors, so they
probably.
would have given induction.
Dr. Hemant,
Yes,
Dr.
yes,
Hemant?
yes, sir. Dr. Dubey is like he's right at this point. If the radiation field is very large, like the tumor size with the mediastinal lymph nodes, like the tumor, the radiation field will be very large. Secondly, if the patient performance status is not good, the patient cannot tolerate concurrent chemoradiotherapy. In that case, also we can opt for induction chemotherapy followed by concurrent chemoradiotherapy or radiotherapy alone.
Yes, as Dr. Dubey and Dr. Hemant rightly said, there is no data for induction chemotherapy as far as survival benefit is concerned, but we all have been using it in selected cases, like if it is difficult to give radiation or there is delay in planning, and some of the patients are already treated outside with some few weekly, or patient's performance status is poor. So probably cytoreduce him with some weekly doses and then maybe take him up for radiation. So concurrent versus sequential, Dr. Rajesh, in which patients you use sequential, in which patients you use concurrent, or routinely, what is your practice?
Routinely use concurrent chemotherapy, sir, concurrent chemoradiation.
And are you using anything apart from paclitaxel carboplatin?
We can use PEMSIS also in adenocarcinoma.
Yes, there are various trials. I think there are trials for even vinblastine.
Vinblastine.
So, but most of us are, I think, more comfortable using paclitaxel carboplatin weekly doses along with radiation. So, what dose of radiation you utilize if you are using concurrent chemoradiotherapy, Dr. Hemant, please?
Right, sir. As per RTOZ 0617, and right, as I said previously also, this RTOG 0617, and there is another like big meta-analysis of 6 randomized phase 3 control trial. They have concluded that standard radiation dose is 60 gray into 30 fraction over 6 weeks. This is the standard radiation dose. Apart from this dose, there are other trials which have tried hyperfractionation and accelerated hyperfractionation also, like 1.5 gray per fraction, 2 or 3 fraction a day, or they have also tried accelerated hyperfractionation, where standard dose like 60 gray and 30 fraction will be delivered over a short period of time instead of 6 weeks. So my standard dose will be 60 gray in 30 fraction over 6 weeks.
Any cases where the tumor is large, where you need to give a boost or something, just for my understanding, on a case-to-case basis, you decide to give boost anytime?
Sir, actually, we don't use boost, but we do adaptive radiotherapy while in between the treatment after, and most routinely after 20 fraction of radiation, we do re-CT, RTP-CT, I mean radiotherapy planning CT, and do adaptive radiotherapy. So that is a kind of boost, like boost therapy only. But here, after 20 fraction of radiation, the volume of radiotherapy and radiation field is significantly reduced. So we do that adaptive radiotherapy.
Okay, if the patient has responded, the tumor volume has shrunk, so probably you modify your field according to that. Thank you so much for that answer. So, of course, we'll be discussing. So these are the outcomes of definitive chemotherapy in unresectable stage 3B. As we can see, there are various chemotherapy regimes have been used. And you can see that the median OS in most of the trials is ranging from anywhere between 23 to 29, 25, 26 months. So we can see that even in a stage 3 disease, a lot of patients are there who are going to progress. And I think with concurrent chemoradiotherapy, the long-term 5-year OS has not been more than 25 to 30%, even in stage 3 disease. And there is definitely data to suggest that concurrent is better than sequential. And if we move, so this is these are various trials which was assisted in a meta-analysis, which has shown that if you are using concurrent chemoradiotherapy, it significantly increases the 5-year survival rate as compared to if it is used in a sequential manner. So unless the patient is a poor PS patient with a elderly, and we have a premonition that probably he's going to tolerate this this treatment poorly, so probably there we can utilize sequential therapy. It also causes reduced locoregional relapse. So the patient was initially given chemoradiotherapy. He was started in July 2021. As Dr. Hemant rightly mentioned, the dose used was 60 gray in 30 fractions, and he was given paclitaxel carboplatin. He was given for 4 cycles. And then chemotherapy was stopped after 4 cycles. So this was the follow-up PET scan. So you can see that there is some residual post-RT fibrosis or some active disease, residual disease. So what will you do after this point? Like Dr. Dubey, you have done at what time point you do a PET scan or just a CT scan after completing radiation?
At least after 10 to 12 weeks, the patient has got definitive radiotherapy. And I'll wait for at least 10 to 12 weeks before
So
I go ahead with the PET.
If the patient is very affordable and you have to start durvalumab, so will you wait for 10 to 12 weeks? After
Durvalumab also, actually, though the timing does not affect the efficacy of the drug, but they have also like the recommendation are to start durvalumab after 10 weeks of completion of concurrent chemoradiotherapy.
My only question was that in the patients in the trial, in the Pacific trial, you have to have at least a partial or a complete response before, or at least a stable disease before you can give durvalumab. So you have to have a response scan. So what response scan, because I have faced this problem that in around 2 of my patients recently, we were planning the patient on durvalumab and that patient progressed. One of them came out to be MET amplified and one of them was actually EGFR positive, which we tested later. So what is your like strategy here?
Yeah, but we must also, if I need to do a response scan, then we can go ahead with CT. But one thing has to be considered that smoking history as well as COPD, as a prior RT, they are already risk factors for immune checkpoint inhibitor associated pneumonitis. So as per me, I will not like be in haste. I'll wait for at least 10 weeks for doing anything with that.
Very rightly said, sir. What I do in my practice, I usually do a CT scan, just abdomen. I know at that point doing an additional FDG because RT-induced inflammation can be seen. At least I try to establish that, okay, the patient is not progressing anywhere and start the patient on durvalumab. And after that, like after 3 months, maybe I'll do a PET scan. Dr. Hemant, any differences of opinion?
There is one guideline which is published by Tata Memorial Hospital, which says that durvalumab can be started any time between first day to 42 days. Is it right, sir?
Yeah, it is there.
Yes.
It is a part of the Pacific trial. In fact, we have now a much larger real-world data from retrospective analysis, which says that even as Dr. Dubey was saying, that a lot of these patients are at a very high risk of toxicity or they take a lot of time to recover. There, the patients have even been started on durvalumab after 42 days. Okay. And those patients have also shown overall survival benefit, at least in the retrospective data.
Right, sir. So the ideal time of response assessment and follow-up is
at least I wait for
2.5 to 3 months.
At least I wait for 2 to 3 weeks. I just establish that there is no progression and then start the patient on durva.
Okay, sir. Okay.
So any other consolidation strategy that you use in your practice, Dr. Rajesh?
Sir, PET scan, definitely there is difficulty in performing PET scan, and PET scan, early PET scan is not give you much information regarding the response rate. So definitely we'll go for a CT and to see whether the disease is adequately controlled or not. And the second thing is that what about the consolidation dose of chemotherapy? So the paclitaxel patient, they need additional 2 cycles of 3 weekly paclitaxel. What would you like to give 3 weekly 2 dose and then go for response assessment and adjuvant durvalumab in a case where the patient is eligible for durvalumab, or you omit?
Adjuvant paclitaxel, I'm not so sure. Maybe Dr. Dubey can answer this question. Are you using adjuvant paclitaxel or anything like that pre-weekly after chemo radiation?
Previously, I used to use, but in this patient has already deranged LFTs. So
Yeah.
I'll be cautious using this particular.
In our center, we also have a FAPI PET scan. So what we are doing is that FAPI PET scan is excellent for differentiating between radiation-induced inflammation versus tumor. So we are routinely doing FAPI in such cases, and it is excellent because it is FAPI is preferentially taken only by the tumor, not by the radiation-induced inflammatory cells. So it has made our job slightly easier, and we are charging the same for the same as the FDG. So even the cost is not different. So that is one of the strategies that we are using recently, and we have compiled the data of around 10-12 patients. So we'll be publishing that data very soon. So basically he had a response. So other consolidation strategies has also been tried in stage 3 patients. So chemotherapy consolidation strategies. There are also data for Jeftinib consolidation, and none of them have shown any survival benefit. As you can see that the median OS remains the same irrespective of the consolidation strategies used. And in fact, it leads to a deterioration in quality of life and more toxicities. Here you can see that people have also tried higher doses of radiation. So we have already discussed that immunotherapy maintenance with durvalumab is now a standard of care based on the Pacific trial. This is the criteria for the Pacific trial. Most of us know about it, that stage 3 unresectable patients who have achieved at least response or stable disease, they were randomized within 1 to 42 days to durvalumab 10 mg per kg every 2 weekly for 12 months or placebo. And the key endpoints were PFS and OS. You can see that the primary characteristics, baseline characteristics were well matched. You can see they have included very few patients of EGFR mutation positive patients also, and they had done PD-L1 analysis also for all the patients. So this is the updated 5-year overall survival. That at 5 years, there are 43% patients who are alive as compared to 33% patients in the placebo. And it was the first only approved IO to demonstrate 42.9% OSS at 5 years. Even PFS separation was maintained. Hello?
Please conclude your talk.
Yes, I will do that. So median OS was 16.9 versus 5.6 months. This was the updated progression-free survival, 16.9 and 5.6. And the real-world data that was done for retrospective analysis from the US Oncology Medical Record Database, there also they have assessed and they have taken patients that they have seen that around only 50% of the patients could start durvalumab within 42 days. Most of the patients, around 50% of patients are starting after that. And almost 40% received durvalumab for more than 11 months. And median follow-up was 17.7. This was the analysis. If you see here also the real world PFS was 17.5 months, which was similar. Median OS has not reached. The data is still immature. So even from the real world data, now we have we have data to suggest that, okay, this drug is working. So the patient was started on Durva and he completed 3 cycles. Follow-up PET scan was suggestive of complete response. There was no uptake and patient had a good response. He was continued on durvalumab, chest X-ray was clean. And in February, he had received a total of 15 cycles of durvalumab. Then again, patient came with chest pain. PET scan was suggestive of recurrence, locoregional recurrence. So what are the options? Dr. Dubey and Dr. Rajesh can take this question quickly.
So the recurrence happened after how much time?
15 cycles of durvalumab, so around 30 weeks.
So no other systemic site of recurrence?
No, it is intrathoracic recurrence only.
Intrathoracic recurrence, if I would like to ask, I would like to take advice of my radiation oncologist whether we'll be able to
I think it is less than 1 year.
So because he has already received 15 cycles, and I don't know how much time it has till the last radiation was received.
It is the same, right, upper lobe.
Yeah, if the duration of previous radiotherapy is more than 1 year, we can consider re-irradiation of this particular recurrent disease with lower dose, respecting the tolerance of heart and spinal cord and lungs. So in this case, like we can
It is
go
less
ahead
than
with.
one year.
Sorry, sir.
It is less than 1 year here.
Okay, so that is a little complicated, but still, if there is no option, we can go ahead with consolidation with radiotherapy. With
I think it indicates a very aggressive disease. Just with a few months, it has recurrence. And probably I would like to treat with chemo. I would maybe, and Dr. Rajesh, what is your opinion? Or any other immunotherapy you would
It is
like to use?
localized recurrence, sir.
Yes.
It's not non-metastatic. So probably one more biopsy and see whether EGFR is negative.
Yeah, negative.
So if radiation is not possible, then next line chemotherapy is one option. Already he is exposed to immuno.
So basically, if you look at the data from Pacific also, most of the recurrences were intrathoracic only. Around 36% of all the 45% patients who regressed. And you can see that the median time to recurrence was 25.2 months versus 9.2 months in the placebo arm. And most of the patients in the recurrent setting, if the patient had received previous durvalumab, they went on to receive chemotherapy only. Majority of the patient, and in the durvalumab, 41% of the patient and 54% of the patient in placebo received a subsequent therapy. Most common therapy used was chemotherapy in patients who had received prior durvalumab. The safety summary, we all know that pneumonitis is more common. We have to be really cautious about it because patient has previously received radiation. So the key takeaways, yes, as we discussed, we had a wonderful discussion with Dr. Hemant and Dr. Rajesh, Dr. Dubey, that MDT approach is something that is best because we can involve surgeons in selected endo diseases, and mediastinal staging with the help of your pulmonologist is important. CCRT is superior to sequential chemoradiation. Consolidative chemotherapy does not lead to any improved outcome. Immunotherapy should be added wherever feasible, and it should be considered as a treatment option in all unresectable stage 3 patients who have not progressed on CTRT, irrespective of PD-L1 status. So I think with that, I will conclude my talk. Thank you so much, and it was an excellent discussion, all the panelists. Thank you so much. Thank you, Dr. Dubey, again.
Thank you, Abhishek. Thanks a lot. So I'll not keep my panelists waiting for long. So this is the second case which will be wrapping it fast. I hope I have the audacity to keep Dr. Shiva, Dr. Dipen, Dr. Kaushik, and Dr. Rajesh. And also I request Hemant to please be on panel. So we'll be finishing it in next 10 minutes or so. So this is a case-based discussion of EGFR mutated lung cancer, so which is the most common driver mutation in patients with non-small cell lung cancer. So this is a case of 54-year-old male smoker, and also has a history of type 2 diabetes. So he was being evaluated for pleuritic chest pain and the shortness of breath. So found to have large left lobe pulmonary mass and histopath adenocarcinoma, and molecular panel EGFR mutated L858R. So I would like to start with Shiv Shankar, that you said about smart NGS in Rajiv Gandhi. So that is like dual, both RNA based and DNA based, or what it is, so that we'll be also able to utilize it. Shiva.
Sir, it is both DNA and RNA based, but it is for specific markers. It does not include like for 65 gene panel or 165 gene panel or 300 gene panel. It includes 8 or 10 genes which are already approved in non-small cell lung cancer. But both, it is both DNA and RNA based, both.
Okay. So if suppose in any of your patient you get HER2 mutated lung cancer, so will you be more inclined towards using HER2/neu based targeted therapy, or in those patients you'll go ahead with chemo or IO plus chemo?
Sir, in first line setting, it's chemo. In second line setting, we'll go for targeted therapy.
Okay, because there's very much chatter about trastuzumab deruxtecan,
but its availability is
okay. Ma'am, if the
cost.
drug is available, you have a driver, you have a drug. So still you will be going ahead with chemotherapy or immunotherapy?
No, if
or
trastuzumab deruxtecan is available, I'll go ahead with
the first line.
Yes,
Although the data is not there for first line.
but in second line, the data is quite promising, sir, compared to chemotherapy.
Okay, fine, fair. Whenever driver is present, one must target the driver. So this patient is EGFR mutated. So next, Kaushik. So among these EGFR TKIs, so what will you suggest to your patient? First generation, second generation, third generation? And what is practice at your institute?
Sir, what I would suggest is, with no cost constraints, obviously third generation osimertinib, we have a beautiful data of Flora. But in our institute, again, the availability is an issue. So usually a second generation followed by.
So Rajesh, I guess you also concur with Kaushik, because you are also working in the same institute. And,
yes, sir.
So
yes, sir. Osimertinib, there is always a problem of availability. If it is available, definitely osimertinib is my choice.
If it is not available, will you go ahead with first generation TKIs or second generation TKIs?
Yeah, but we use more first generation TK than second generation TK. Second generation TK, again, availability is and tolerability is a factor.
Yes.
So,
if I would be given choice, I'll also go ahead with first generation EGFR TKI, because second generation EGFR TKIs, both afatinib and dacomitinib, they are associated with at least 2/3 of the patient will have some dose modifications, some sort of adverse events, and all these things. Deepen, any subgroup of patients you'll surely go ahead with the second generation EGFR TKI?
Sir, with the first choice would be the osimertinib. But if patient is availability is issue or the patient is not affordability, so I would suggest for DL19, afatinib would be the better choice for a first generation based on LuxLung 7 subgroup analysis.
Okay. Shiva, for uncommon mutation, you'll go ahead with afatinib or osimertinib if you have both the drugs are available to you?
Sir, I prefer afatinib.
Afatinib, because you have
And
complete
also
data.
in this particular case, since it is L858R, if I have to choose between first and second generation, dacomitinib has shown OS benefit also in this particular subset, L858R. If you see osimertinib in the trial, Flora trial, osimertinib versus first generation, there was no OS benefit in L858R, though there was a clear-cut PFS benefit. But in dacomitinib trial, in L858R, there is OS benefit also.
But in dacomitinib trial, I guess
66% of the patients required dose reduction. I agree that, sir.
So anyways, this one, for uncommon mutations, will you be going ahead with afatinib or osimertinib? It's afatinib, right? Shiva?
Yes, sir. Yes, sir.
Okay.
Both are options. I prefer afatinib.
You will prefer afatinib. Okay. So still, because we have data with afatinib for uncommon mutation, but we have some certain anecdotal data as well as observational studies with osimertinib, where the response rates are more than 50% with osimertinib also. So that remains an alternative choice. So, Deepen, any experience with erlotinib plus bevacizumab? Like, when will you use such combination?
Sir, till now I haven't experienced with erlotinib bevacizumab, but certainly a reasonable and good choice whenever the osimertinib is a issue with the patient's finances. Erlotinib plus bevacizumab would be a good option for them.
Okay.
May I, sir?
Yeah, Kaushik.
Sir, even the erlotinib and ramucirumab has a good data in this L8 FATR subset, sir.
Yeah. With specific L858. Now, I just want to ask that, have you used erlotinib plus bevacizumab or osimertinib plus bevacizumab?
Negative.
Shiva?
Sir, I have used bevacizumab plus osimertinib, particularly that patient was on osimertinib for almost 1 year. She failed in brain. We irradiated. Again, we continued on osimertinib after irradiation, again failed. Then we added bevacizumab. With osimertinib and bevacizumab, we could pull her for another 1 year.
Very interesting discussion. And because I also used this in 2 patients, and I have used the dose of 120 mg of osimertinib plus bevacizumab, though patient was not able to tolerate. And he was
160.
a paramilitary soldier. And for 3.5 hours, 3.5 months, he actually continued that therapy. Ultimately, he succumbed to his malignancy. So anyone used osimertinib more than 80 mg per day?
I have used 160 mg also, sir.
160 mg in which patients?
CNS patients who have progressed on osimertinib 80 mg. I've used 160 also.
So what was the response?
Again, they progress.
Means they didn't. Okay.
They didn't respond.
Okay. Anyone else having the experience of using osimertinib more than 80 mg per day? Kaushik, Rajesh, Deepen?
Sir, we had one patient, sir, who had progressed on first generation, then had T790IM. We had osimertinib shortage. In that, we had tried 80 per week, sir, and he was doing better.
80 per week?
Yes, sir. Unconventional, but availability is the issue.
Okay. Maybe because already we have the data of nivolumab of 20 mg, 10 mg. So that is working. So mostly that's not surprising. But yes, I have also added bevacizumab to osimertinib in patients who have actually failed on osimertinib and have brain metastasis. And I have also increased the dose of osimertinib at least in 2 patients. And 1 patient have actually responded, though the tolerability is the problem. So as we all know that osimertinib is the preferred first line, the FLORA study, and there's no doubt in that. But other recommended, we must always remember that category 1, second generation and first generation TKIs are also there when osimertinib is not available due to some cost issues or availability issue, as already Dr. Rajesh and Dr. Kaushik has mentioned. So one by one, I wanted to ask first, Kaushik, like what are your primary goals in a metastatic lung cancer patients, maybe EGFR mutated or whatsoever? So among all these options, Kaushik.
Safety and quality of life along with it.
Safety and quality and overall survival you would not like?
Yes, sir, but still it stands later on because in any of it's
Okay. Deepen?
Sir, actually, all parameter matters: efficacy, safety, quality of life, and OS. Based on the performance status, the side effect and the drug side effect profile, and the efficacy in overall side effect, equally balancing, I would like to choose, sir. Because as earlier discussed in this session, sir, second generation EGFR TKI, the toxicity profile is more. So I would rank them inferior compared to first generation. That's it.
Okay. Is Hemant there? Dr. Hemant?
Yes, sir. Yes, sir.
Yeah, I would like to ask your opinion on this.
Sir, can you repeat the question, please?
So what are your primary goal in a metastatic lung cancer patient, whatever, if it is driver mutated positive or driver mutation negative, efficacy, safety, quality of life, or overall survival?
I think quality of life is a more important thing in this profile of patient, because we all know that this is metastatic disease, and OS, of course, we know that whatever we give, the overall survival is limited in such profile of patient. So maintaining quality of life is like primary point of attention.
I guess we have read every time that the primary goal is to prolong the survival and maintain the quality of life. And if we are maintaining the quality of life, I guess we are imbibing the safety in it. And if we are prolonging the survival or trying to prolong the survival, then efficacy is ultimately automatically coming into it. So as for me, all four are as important as one can. So this is about the different TKIs in EGFR mutated non-small cell lung cancer. And you can see the first line, erlotinib versus gefitinib, giving a PFS of 13. That time there was no overall survival benefit. Afatinib versus gefitinib and dacomitinib versus gefitinib. Osimertinib versus erlotinib. That in FLORA study, it has almost doubled the progression-free survival in FLORA phase 3. So one cannot deny with this particular fact. And the drug itself is well tolerable. So will type of mutation change your choice of EGFR TKI? We have already addressed that. Yes, the uncommon mutations will go ahead with afatinib because it has very concrete data. But always we'll try to remember that osimertinib is still an alternative choice for us. So will the type, there are the PFS plots in that it is very clearly been mentioned that osimertinib is also very well suited in patients with uncommon mutation, though we don't have phase 3 data for that. So be it exon 19 del or L858R mutation, PFS is longest with osimertinib. We know that because these are the common mutation. Exon 19 del is around 45% and L858R, which is exon 21, that accounts for around 20% of the mutation. And in the Archer study, which is dacomitinib, here the CNS Mets patients were actually excluded. One must remember that though dacomitinib has given better results as compared to other second generation TKI or the first generation TKI, but here the CNS Met patients were excluded, whereas in all other trials, controlled or asymptomatic CNS Mets were actually included. Osimertinib has shown highest overall response rate and median duration of response. So Shiva, so we have only one EGFR TKI which has shown overall survival benefit. That what you were talking about dacomitinib. In dacomitinib, it was the statistical design was hierarchical. Only if
objective response rate, statistical significance was there, then they could have analyzed. I agree that.
So
they could not assign a p-value.
That means we are left with only one TKI with overall survival benefit. And in a metastatic disease, our aim is to prolong the survival. So now, if you have an uncommon mutation, so which drug you will choose, afatinib or osimertinib?
Sir, in uncommon mutation, we do not have a data for any overall survival benefit with any of the drugs. It's all case series or single case studies. So since cost is also issue, without any, proper evidence, I'll still go with afatinib.
But in all other most common mutations?
Most common mutation, definitely it is because not only the OS benefit, it's also safety. So definitely safety, quality of life and efficacy, all the four, I'll get a tick with osimertinib. So I'll go with osimertinib. Okay. The question that time was first generation and second generation TKI, what would I choose among them if I don't have a osimertinib? Definitely in the situation in L858R, it is dacomitinib, because in that L858R, it was also shown in that subgroup, OS benefit was there. What you had shown was PFS benefit in osimertinib, but if you see the forest plot for OS benefit in L858R, it was exactly sitting on the line of unity.
Fair. Rajesh, overall survival, how important it is for choosing an EGFR TKI, knowing that only osimertinib is the EGFR TKI with documented overall survival. This is the FLORA.
Other TKI, second generation TKI, even afatinib also has some overall survival benefit in the rare mutation groups. Sir.
No, afatinib actually did not show.
Did not overall. There was no OS benefit, but there was some OS benefit in the rare mutation group. In afatinib.
Okay. In uncommon mutations, yes. Yeah. In uncommon mutations, that is very much clear that we have concrete data of afatinib, so we'll choose afatinib. But in common
So
mutations,
choosing the TKI here, so I give more stress on the performance status of the patient. Second is the brain mets. For patients with brain mets, definitely the osimertinib will be the first choice. And second thing is the mutation, types of mutations.
fair.
And the affordability, definitely the affordability.
So this was what Shiv Shankar was discussing, the Archer trial, which actually showed OS benefit. There is good numerical OS benefit, but the statistical design was hierarchical, that only if overall response rate is significantly better, then only we could calculate for the overall survival. But there was no significant benefit, or difference in ORR. So this, I guess, already Rajesh has told that, yes, patients with CNS metastasis will surely consider osimertinib as the drug of choice. But also one must be very much clear that the incidence of brain metastasis in driver mutated patient is slightly higher. It's around 20% at the onset, and cumulative incidence is around 40 to 50% at the end of 2 to 3 years. So will that thing not like provoke you, or the data of osimertinib does not impress you to start osimertinib in all patients with EGFR mutated non-small cell lung cancer? Kaushik?
Definitely, sir. In the common mutations, you know that the targeted patients with these mutations are prone for CNS metastasis, and here obviously osimertinib has an upper hand over here. But again, if availability is not an issue, we'll go with osimertinib.
Okay. So this we already. So do you routine, Dipen, do you routinely do CNS imaging in all your patients with metastatic disease?
No, sir. Currently, as a theoretical aspect, I would like to go for the MRI brain. But with symptoms, I am currently practicing MRI brain in stage 4.
But actually, guideline says that all the
Yes,
advanced.
sir. Agree.
Okay.
Agree.
So these are the NCCN guidelines, where it is very clearly said that all the patients should be actually in metastatic setting, so should be actually screened for brain, because one can have a very localized approach to that, and those patients' overall outcomes can be actually improved. So we have actually discussed all these trials, that in Archer trial, all brain mets were excluded. That is the very significant difference between all these TKI trials that we must be very much aware of. And around 1/5 of the patient in the FLORA study were having brain metastasis. So these are the comparable reports, and where you can see that the dacometinib trial not having or including brain metastasis patients. And also we have the response rate of osimertinib, that is 66%. And also CNS PFS is not reached versus 13.9 in osimertinib FLORA study, which is quite impressive. And in patients with the asymptomatic metastasis, it is 15.2. So this is a very common thing. Shiva, that will PDL1 positivity in EGFR mutated lung cancer favor in starting IO in this patient?
In first line setting, sir?
Yeah, in first line setting.
No, no.
So Kaushik?
No, sir. We definitely know by now that these patients
Yeah,
poorly
because patients with driver mutation, they have very poor response to immunotherapy. Only one trial, which is immunotherapy trial, which has shown or which has included the patients, that too also post progression on the TKI, that is IMPAR 150, but that has included immuno plus Bev plus chemo. That is the only trial which has shown improvement in outcomes with the use of immunotherapy in these subgroup of patients. So how important is safety? I guess we have already mentioned that the safety profile of the second generation TKI is quite haywire, and the first generation is okay, but the efficacy is low, and the third generation of osimertinib well tolerable and very few permanent discontinuation. So the quality of life also we have already discussed that yes, our aim remains to prolong the survival with maintaining the quality of life and reducing the side effects as far as possible. So these are the trials we have already considered. Okay, so Shiva, so any patient, do you think that sequencing is the best? This is the last question we'll all will be answering. So do you think that sequencing will remain a good financial approach? That first generation TKI, if the patient progresses on first generation TKI, then a third generation TKI, or directly upfront third generation TKI?
Sir, I think that's the geotag study probably you are trying to look at, that which has shown that afatinib followed by osimertinib has shown median OS of 42 months. But only, I mean, 1/3 of patients may end up going through that option. I'll not advocate sequencing of therapy. I'll advocate upfront osimertinib. Sir.
Fair. Kaushik?
Aptly alluded by Shiva sir. Actually, if it's not an issue getting the osimertinib, then upfront osimertinib is the standard of choice here.
Okay, and Rajesh?
Definitely with this crossover of patients, 47% percentage, osimertinib has a good overall survival. So upfront osimertinib is database better than sequencing. But in our setup, we use usually sequencing therapy because of the financial aspect.
Yeah, when available, but osimertinib should be used as upfront because we don't know that whether the progression is to that state, that whether we'll be able to, what that precludes the use of other subsequent therapies or not. So the first and the best therapy should be used first. So I guess we are done with it. And this geotag already. So osimertinib has actually resulted in very significant improvement in progression-free survival as compared to first generation TKI, that is almost doubling. And it is the only TKI which has shown the significant CNS PFS benefit over standard of care in third generation TKI with very fewer CNS progressions. And it is the only TKI which has shown the statistically significant overall survival. And after 3 years of osimertinib, 28% of the patients were actually remain on the first line treatment, whereas only less than 10% remain on the first generation TKI. So the final OS analysis of FLORA reinforces the use of third generation osimertinib as the standard of care first line treatment for the patient with EGFR mutated advanced lung cancer. So with this, I thank all my panelists, Dr. Shiva, Dr. Kaushik, Dr. Rajesh, Dr. Dipen, Dr. Hemant. A very big thanks to be here and delaying them for their dinner. And thanks for joining this. And thanks a lot.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, everyone. Thank you, everyone, for joining for a nice panel discussion and presentations. Good night, everyone.
Technical team, please close the meeting.
Thank you, Gitika. Thank you, Nishant.
Thank you so much, ma'am. Tech support, are you there?
Technical team, please close the meeting.